Welcome back, everyone. Today on Health Code Blueprint, we're diving into Chapter 5 of ICD 10-CM, which covers mental, behavioral, and neurodevelopmental disorders, codes F01 through F99. In this session, we're going to break down the key guidelines in this chapter, walk through special considerations, look at sequencing rules, and make some important conclusions based on what we review. Before we begin, here's a quick disclosure. This presentation is for educational purposes only. It does not constitute legal, compliance, or billing advice. Always follow official ICD 10-CM guidelines, organizational policies, and regulatory requirements. So, let's get started. Chapter 5 can feel overwhelming because it covers so many different behavioral and psychological conditions. This guide focuses on 4 areas that tend to cause the most confusion: pain disorders with psychological factors, psychoactive substance use, factitious disorder, and dementia. Each section builds clarity and confidence so you can code these conditions accurately. Let's start with pain disorders. On the clinical side, it's important to understand what we mean when we talk about pain related to psychological factors. This type of pain can be influenced by mental or emotional stressors, and it often shows up as pain that doesn't fully match the patient's physical findings. Some common examples include headaches, muscle pain, back pain, or stomach pain, all of which can be intensified or prolonged by psychological factors. Another key feature is the absence of a clear physical cause. In these cases, the pain occurs without a physical injury, illness, or known pathophysiological mechanism that fully explains the symptoms. That's why the provider's documentation is so important. In this module, we're going to break down how to tell the difference between pain that is purely psychological in origin and pain where psychological factors are simply contributing to an existing acute or chronic pain condition. And that distinction matters because it determines whether you assign an F45 code by itself, or whether you need to pair it with a G89 pain code to capture the full clinical picture. When it comes to pain, the provider's documentation is everything. If the pain is described as exclusively psychological, meaning the physical sensation is caused, increased, or prolonged primarily by mental, emotional, or behavioral factors rather than a physical injury or illness, then we follow one coding path. But if psychological factors are simply influencing the pain, that's a different situation. In these cases, emotions, thoughts, stress, anxiety, depression, or even catastrophizing can change how the patient perceives pain. These mental states can amplify or dampen pain signals through brain pathways, sometimes worsening pain even when there's no clear tissue injury. This is where the mind-body connection becomes very important. Understanding the difference between pain that is purely psychological and pain that is physically based but psychologically influenced is the key to choosing the correct code. Here's where the rules get specific. F45.41 is used when the pain is exclusively psychological, and you should not assign a G89 code with it. But F45.42 is used when psychological factors are contributing to acute or chronic pain, and in that case, you must assign a G89 code alongside it. So again, everything depends on how the provider describes the relationship between the pain and the psychological component. Next, let's move into psychoactive substance use, one of the most rule-heavy parts of Chapter 5. This section covers the hierarchy of use, abuse, and dependence, how to code remission, and how to handle related medical conditions. From a clinical standpoint, the DSM-5-TR provides the criteria used to determine the severity of a substance use disorder, and our code assignment must always match the provider's documentation. If something doesn't align, that's when a query is appropriate. The DSM-5-TR groups symptoms into 4 main areas: impaired control, taking more than intended, unsuccessful attempts to cut down, spending excessive time using, or experiencing cravings. Social impairment, problems at work, school, or home, or giving up important activities because of substance use. Risky use, using in dangerous situations or continuing despite physical or psychological harm. Pharmacological criteria, tolerance and withdrawal. Severity is based on how many criteria the patient meets: mild with 2 to 3 symptoms, moderate with 4 to 5, and severe with 6 or more. Remember, code assignment must always be based on the provider's documented statement indicating the severity of the condition. If the severity isn't clearly documented, we can't assume it, and that's when a provider query may be necessary. This is one of the most important rules in the entire chapter. When the provider documents multiple patterns for the same substance, you only assign one code, and you follow the hierarchy. Dependence overrides abuse and use. Abuse overrides use. And if only use is documented, then you code use. It's a strict hierarchy, and it keeps coding consistent. Now let's talk about remission. In the DSM-5-TR, remission is a clinical specifier used when someone who previously met the full criteria for a substance use disorder no longer meets any of those criteria, except for craving, which can still be present. From a coding standpoint, remission can only be assigned when the provider documents it. If the disorder was mild and is now in remission, we assign the remission code for abuse. If the disorder was moderate or severe, the remission code falls under dependence instead. So, the key takeaway is that the documented severity determines the correct remission code. Sometimes substance use leads to a medical condition, but that doesn't automatically make it a substance-induced disorder. Substance-induced disorders are psychiatric conditions caused by the direct physiological effects of a substance. In the DSM-5-TR, these require symptoms to develop during or shortly after use or withdrawal. On the other hand, a medical condition due to substance use is a physical health problem caused by the substance's impact on the body, things like organ damage or inflammation. These are not classified as substance-induced disorders, and they often involve structural changes that don't resolve just by stopping the substance. When this happens, coding follows a specific sequence. You code the medical condition first, and then the appropriate substance use code. The official example is alcoholic pancreatitis. You code the pancreatitis first, followed by the alcohol dependence. Getting this sequencing right is essential for accuracy. There are two special considerations in this section. First, unspecified substance use codes should only be assigned when the provider clearly documents a relationship between the substance and another condition. These codes aren't meant to be used loosely, the documentation has to support the connection. Second, let's talk about blood alcohol level codes from category Y90. These can be assigned when a blood alcohol level is documented, and the documentation doesn't have to come from the provider. It can come from nursing, lab staff, or other clinicians. However, a Y90 code can only be used if the provider has already documented a condition that falls under category F10, which includes alcohol intoxication, alcohol use disorder, or alcohol withdrawal. In other words, the F10 code represents the primary clinical condition, and the Y90 code is simply supplemental detail. Because Y90 is an external cause code, it should always be reported as a secondary diagnosis. Together, these codes help create a more complete and accurate clinical picture. Now let's shift into factitious disorder, a topic that requires careful attention. The key question here is, who is the patient of record? Because the code you assign depends entirely on whether the person is harming themselves or someone else. Factitious disorder imposed on self is coded with F68.1. This is when a person falsifies or induces symptoms in themselves. But factitious disorder imposed on another, also known as Munchausen by proxy, is coded very differently. The perpetrator receives code F68A, and the victim is coded with abuse codes from T74 or T76. So again, always identify whose chart you're coding. Next, let's talk about dementia. Dementia coding depends on two things, the etiology and the severity. In inpatient settings, severity can change during the stay, which affects the final code. Severity must always come from the provider. If severity isn't documented, you assign the unspecified severity code. But if the patient's dementia progresses during an inpatient stay, you assign one code, and it should reflect the highest severity level documented during that stay. Never infer severity. Always code exactly what the provider states. Before we wrap up, let's highlight the core principles that guide accurate coding in Chapter 5. These principles apply across pain disorders, substance use, factitious disorder, and dementia, and keeping them in mind will help you code with confidence. Principle 1. Provider documentation is paramount. Every decision you make, whether it's determining the pain pathway, identifying the correct substance use hierarchy, or assigning dementia severity, must come directly from what the provider documents. We never infer, assume, or interpret beyond the provider's words. Principle 2. Hierarchies and exclusions drive precision. Chapter 5 includes strict rules, like the substance use hierarchy, and excludes one notes. These aren't suggestions, they're required logic built into ICD 10-CM. Following them ensures your code selection reflects the classification accurately. Principle 3. Always identify the correct patient of record. This is especially important in conditions like factitious disorder imposed on another. The perpetrator and the victim receive completely different codes, so always ask yourself, whose chart am I coding? These 3 principles form the foundation of accurate Chapter 5 coding and help ensure that every code you assign truly reflects the clinical picture. And finally, here's your Chapter 5 checklist, the 4 questions to ask before finalizing a code. Is the pain psychological, contributory, or both? Did I apply the substance use hierarchy correctly? In factitious disorder, am I coding the perpetrator or the victim? And for dementia, does my code reflect the highest documented severity? Keeping these questions in mind will help you code Chapter 5 conditions with accuracy and confidence. Thanks for joining me today on Health Code Blueprint. If you found this helpful, don't forget to like, subscribe, and check out the next module in our ICD 10cm series.